What if I told you that if someone is having a heart attack, slapping an oxygen mask on their face might actually make the heart attack worse?
Yeah, which is completely counterintuitive, right?
Exactly. I mean, for decades, it was absolute standard procedure. It was just, first aid 101.
Oh, absolutely.
But modern medicine has completely flipped the script.
Mm.
And doing what feels like the most instinctive, helpful thing in the world could actually be destroying more heart tissue.
It's a massive paradigm shift.
Yeah.
And it really highlights how what we think we know about emergency medicine, especially, from watching movies or TV,
Yeah.
is often lagging way behind the actual science.
Right. The classic TV medical drama,
Yeah.
pure adrenaline and chaos, people running down hallways. But then you look at actual modern emergency medicine and you realize it's less like an action movie and, well, much more like a high-speed,
Hmm.
incredibly precise game of chess.
It has to be. I mean, the
Yeah.
reality of a cardiac event in the ER
Mhm.
is governed by these rigorous, constantly evolving algorithms.
Right.
We might like the drama of the TV show, but patients survive because of the strict science of the guidelines.
And that is exactly what we are going to explore today. Welcome to the deep dive.
Glad to be here.
Today, we're demystifying the newly updated American and European guidelines for acute coronary syndrome, or ACS, and we're using this stack of incredibly detailed medical notes shared by Dr. Asifola.
Yeah, these notes are fantastic.
They really are. And our mission today is to translate this dense, life-saving medical data into clear, fascinating insights. We want to act as your shortcut to being well-informed.
Exactly.
We're going to help you understand exactly what happens in the ER during a cardiac event and, how modern medicine has essentially rewritten the rulebook on heart attacks.
I love looking at these notes because they provide this really powerful look at how critical thinking works on the front lines.
Yeah.
They show us how clinical guidelines aren't just static rules carved in stone. They adapt to new evidence to save lives. It's a perfect example of how science constantly course corrects.
Okay, let's unpack this. Because before we can understand how doctors treat a heart attack, we really have to understand the physical reality of what is happening inside the blood vessel.
Right, the plumbing problem.
Exactly. The source material outlines the pathophysiology, and it all starts with something called a vulnerable plaque.
Yes, the vulnerable plaque. This is essentially the starting pistol for acute coronary syndrome.
Okay.
When we talk about plaque in the arteries, we aren't just talking about a uniform blockage like a pipe slowly filling up with sludge.
Right, that's how everyone pictures it.
Exactly. But a vulnerable plaque has a very specific, highly dangerous structure.
Yeah.
It had this large lipid core, meaning a massive center of highly inflammatory fat and cholesterol, and it is covered by a very thin, fibrous cap.
So it's basically like a microscopic pimple inside your artery, just waiting to pop.
That is a very visceral way to put it, but yes,
Yeah.
it is structurally incredibly fragile.
Okay.
And when that thin, fibrous cap ruptures or erodes, the toxic contents of that lipid core are suddenly exposed to the bloodstream.
Which is bad.
Very bad. Your body immediately recognizes this as a severe injury. So it triggers platelet activation.
Okay, so the body's repair crew.
Right. The platelets, which are the cells responsible for clotting, rush in to patch the cut. And this creates a thrombus, or a blood clot, right there inside the coronary artery.
And that sudden clot is what cuts off the blood flow?
Exactly.
To make sense of the source material here, I was, thinking about it like a highway traffic analogy.
Okay, let's hear it.
Imagine the coronary artery is a major multi-lane highway bringing vital supplies, blood and oxygen to the heart muscle.
Right.
That vulnerable plaque rupturing is like a massive truck spilling hazardous debris all over the road.
I see.
And the emergency response, the platelets, they rush in to surround the debris and contain the spill, but in doing so, they block the actual lanes.
I really like that analogy.
Eh.
And depending on how many lanes are blocked by those emergency crews, the patient falls into one of three specific clinical entities of acute coronary syndrome. The guidelines refer to these as the big three: unstable angina, NSTEMI, and STEMI.
Right. So let's stick with the highway. If you have a subtotal occlusion, meaning a few lanes are closed by the clot, but traffic is still, somehow squeezing by on the shoulder, you have either unstable angina, which doctors abbreviate as UA, or you have an NSTEMI.
Correct. The blood flow is severely restricted, but it isn't entirely cut off.
Okay, so what about the third one?
Well, if that thrombus grows out of control and creates a total occlusion, meaning every single lane of the highway is completely shut down and absolutely nothing is getting through, that is a STEMI.
But wait, if we have two conditions that are both technically subtotal occlusions, unstable angina and NSTEMI, how are they different from each other? I mean, they both sound like partial blockages.
If we connect this to the bigger picture, the critical difference comes down to cellular survival.
Okay.
In unstable angina, you have a non-occlusive thrombus, meaning blood is restricted. But crucially, there is absolutely no necrosis yet.
Necrosis meaning tissue death.
Right. The heart muscle is starving for oxygen. It is screaming in severe pain, but the cells haven't actually started dying.
But in an NSTEMI.
In an NSTEMI, you also have a non-occlusive thrombus, but the starvation has gone on long enough, or the restriction is severe enough, that you do have necrosis.
Oh, wow.
Yeah, the heart muscle cells are actively dying. They're passing the point of no return.
And of course, in a STEMI with a complete highway occlusion, you have massive, rapid necrosis.
Exactly.
You know, the notes also briefly mention a completely different scenario called type 2 MI or secondary ACS.
Ah, yes.
And this one kind of blew my mind because it doesn't involve that plaque rupture at all. It's just demand ischemia.
Right.
Meaning the body is under such extreme stress from something else entirely like severe anemia, a crazy fast heart rate, or a massive systemic infection like sepsis, that the heart is working so hard it basically starves itself of oxygen without there ever being a clot in the artery.
Exactly. The demand for oxygen simply outpaces the supply. It is, and it's a crucial distinction for doctors to make on the fly. Because, treating a blocked artery is a completely different medical strategy than treating an underlying systemic infection.
So, knowing that the level of highway blockage determines the amount of permanent heart muscle death, how do doctors instantly figure out which of the three types of ACS is happening?
Right, because they can't just look inside the artery.
Exactly. When a patient rolls through the ER doors, clutching their chest, what do?
This is where the rapid detective work comes in. They rely on two main tools to categorize the event: chemical markers in the blood, specifically troponins, and the electrical map of the heart, the ECG.
Let's talk about troponin first. Because the notes explain that troponin levels are perfectly normal in unstable angina, but they're elevated in both NSTEMI and STEMI.
Right.
Let me see if I can deduce this based on what we just talked about.
Go for it.
If troponin is a protein that is supposed to live inside the heart muscle cells, and we are suddenly finding it floating around in the bloodstream, that must mean the cells are literally popping open and spilling it, right?
You hit the nail on the head. It only leaks out into the blood when a heart muscle cell dies and breaks apart.
Okay.
So remember how we said unstable angina has no necrosis?
Right. No dead cells.
Exactly.
Oh.
No dead cells means no leaked troponin. The blood levels stay normal. But in NSTEMI and STEMI, the tissue is dying. The cells rupture, the troponin leaks out, and the blood test catches it.
And the updated guidelines highlight a major operational shift here called the ESC 0-hour, 1-hour algorithm.
Yes, this is huge.
This relies on high-sensitivity troponin tests. I mean, in the old days, you might have to sit in the ER for 6 hours, terrified, waiting to see if your troponin levels rose.
Yeah, the old waiting game.
But these new high-sensitivity tests are so incredibly precise, they allow doctors to safely rule out a myocardial infarction, a heart attack at 0 hours right when you arrive, and again at just 1 to 2 hours. That is a massive upgrade in ER efficiency and, honestly, patient peace of mind.
It entirely changes the workflow of the emergency room. But, troponin still takes a little bit of time to process in the lab, even with high sensitivity tests.
Sure.
The absolute fastest tool they have, the one that gives immediate answers, is the ECG, the electrocardiogram. This measures the electrical activity of the heart in real time.
Right. And the source text outlines very specific, critical ECG differences.
Yes.
For unstable angina and NSTEMI, the ECG might show what's called ST depression or T-wave changes, but a STEMI shows a very distinct ST elevation of 1 millimeter or more in at least 2 contiguous leads.
Exactly.
Or, the notes say it might show a new left bundle branch block, an LBBB.
Okay, we have to pause here because that is a lot of textbook jargon.
It is a lot of letters.
Let's break down the why. Why does a partial blockage cause a depression on the graph, but a total blockage causes an elevation?
What's fascinating here is the sheer physics of electrophysiology.
Think of the heart's electrical signal as a wave of energy trying to travel through the muscle tissue.
Right.
If the muscle is only partially starved of oxygen, which happens in an NSTEMI, because some blood is getting by, the tissue is sick, but not entirely dead all the way through the heart wall.
Okay, that makes sense.
So the electrical wave struggles to pass through that sick inner layer. It effectively sags or delays, which registers on the ECG machine as a depression, a dip in the ST wave.
Okay, so the signal is depressed because it's struggling through starving sick tissue.
Exactly. But in a STEMI, the artery is totally blocked. The necrosis is massive, and it spans the entire thickness of the heart wall.
Oh, wow.
Yeah, that tissue is dead, and dead tissue doesn't conduct electricity.
Right.
So when the electrical wave hits that solid wall of dead tissue, it essentially has to arc or elevate over the dead zone, completely altering the electrical vector.
Which causes the elevation.
Yes. The machine reads that massive disruption as a sharp ST elevation.
That makes so much sense. And what about that left bundle branch block, the LBBB?
Imagine the heart has a very specific set of high-speed electrical wiring to keep the beat synchronized.
Yeah.
The left bundle branch is one of the main cables. If an ECG suddenly shows that cables completely blocked a new LBB, it means something catastrophic just happened to the wiring.
Like a massive power failure.
Exactly. Often because a massive chunk of the heart muscle just lost its blood supply. It's treated as a blazing red alarm bell, just like an ST elevation.
And that alarm bell dictates the ticking clock, right?
Oh, absolutely.
The guidelines are incredibly strict on this timing. For a STEMI, because the artery is totally blocked and massive tissue death is happening by the minute, the patient requires PCI, percutaneous coronary intervention, which is usually a physical stent placed in the artery.
Right.
And they need that within 90 minutes of first medical contact. 90 minutes.
It is an absolute race against the clock.
Yes.
Time is muscle is a phrase often used in cardiology. Every minute counts.
Well, this is where I want to push back a bit, or at least ask a question based on a specific case study from Dr. Asfafula's text.
Sure, let's hear it.
There is a multiple choice question in the notes about a 58-year-old woman. She comes into the ER with 45 minutes of severe chest pain while resting.
Okay.
Her ECG shows ST depression in leads V3 through V6, and her serial troponins at 0 and 3 hours are both heavily elevated.
Okay, let's track the clues. She has severe pain, ST depression, and elevated troponin.
Right. So I'm looking at this and thinking, wait a minute, she has elevated troponins, which we just established means her heart muscle cells are actively popping open and dying.
Sure.
She is in severe crushing pain. Why isn't she being rushed to the catheterization lab for surgery within 90 minutes like a STEMI patient? I mean, why isn't everyone panicking?
I love this question because it hits at the exact clinical distinction the guidelines are trying to enforce.
It just seems so urgent.
It feels entirely counterintuitive when you hear heart muscle is actively dying to not rush to surgery.
Right.
But we have to look at the whole diagnostic picture.
Okay.
Because her ECG shows ST depression and not ST elevation, she has an NSTEMI, not a STEMI.
So because it's a subtotal occlusion, some blood is still getting by on the shoulder of the highway.
Exactly. It is a serious life-threatening situation, absolutely. But it does not require the immediate 90-minute panic mode.
Interesting.
According to the guidelines, an NSTEMI has a reperfusion window of 24 to 72 hours.
That's a huge difference.
It is. Now, unless she has high-risk features like her blood pressure crashing or deadly arrhythmias, which would shrink that window to under 2 hours, the doctors actually have time to stabilize her medically.
Like using drugs.
Right. Use drugs to calm the heart down before going in to physically fix the artery. It's about matching the aggression of the treatment to the exact severity of the blockage.
Okay, that makes sense. We aren't ignoring her, we're just solving the problem logically.
Exactly.
So this narrative brings us to the actual treatment phase. We've solved the detective work. Now how do we fix it? And this is where the updated guidelines have totally flipped the script on traditional medical dogma.
They really have. It is a perfect illustration of why medical guidelines have to be fiercely debated and updated regularly.
For a long time, the standard ER protocol for chest pain was a mnemonic called MONAB, morphine, oxygen, nitrates, aspirin, and beta blockers.
Very famous mnemonic.
Yeah, it was taught in every medical school, but the new updated guidelines have shifted to a completely different mnemonic, Batman.
Batman.
And honestly, you have to appreciate the fact that doctors probably spend half their time in medical school at 3 a.m. just trying to invent cool acronyms so they don't forget things.
Oh, Batman is definitely memorable, which is exactly what you want when someone's life is on the line.
Right. So it stands for beta blocker, aspirin, ticagrelor, which is an antiplatelet, morphine, anticoagulant, and nitrates.
Right.
But the letters themselves aren't the shocking part. Here's where it gets really interesting, going back to our very first point today. Let's talk about oxygen.
Right. Oxygen seems like the most intuitive, foolproof treatment in the world.
Exactly.
The patient's heart muscle is literally starving for oxygen. So obviously you give the patient oxygen, It's common sense.
You'd absolutely think so. If you're in the ER with a loved one who is clutching their chest, your instinct is going to scream at the doctor to put an oxygen mask on them.
Of course.
But you have to understand why the doctor is going to say no. The updated notes specifically state that routine oxygen actually increases infarct size in normoxic patients.
Which is wild to think about.
Infarct size being the amount of dead heart tissue. The guidelines say it should only be given if their oxygen saturation is actively dropping below 90%.
It's hard to accept, but the underlying physiology here is fascinating.
Okay, break it down for me.
Providing supplemental oxygen to a patient who already has normal blood oxygen levels, a normoxic patient can cause intense vasoconstriction.
Vasoconstriction, so shrinking the blood vessels.
Right. It actually forces the blood vessels to clamp down and narrow, further restricting whatever little blood flow is making it to the heart. It's the exact opposite of what you want. And on top of that, excess oxygen increases the production of reactive oxygen species.
Which are what?
They're essentially destructive molecules that cause even more cellular damage to the already stressed heart tissue.
So just throwing an oxygen mask on everyone who comes in with chest pain, which we did for decades, was actually doing active harm.
In many cases, yes.
That is wild. And it's a very similar story with morphine.
Right. The M in both Morin and Batman.
Yeah, the old Monin AB protocol had morphine right at the front of the line. It relieves severe pain. It calms the terrified patient down. But the updated Batman guidelines say morphine should be avoided routinely.
Avoided.
Yeah, it should only be used for refractory pain, meaning pain that stubbornly won't go away with other treatments, because it may actually increase mortality in NSTEMI patients.
Wow.
I mean, why on earth would a painkiller increase mortality?
This raises an important question about how we view comfort versus actual medical outcomes.
Okay.
What we've learned is that morphine drastically slows down gastric emptying.
Meaning the stomach.
Right. It basically paralyzes the gastrointestinal tract.
Yeah.
And that matters because it delays the absorption of the really critical oral medications we are frantically trying to get into the patient's system.
Ah, like the pills.
Exactly. Specifically, the anti-clotting drugs. If those life-saving drugs are just sitting in the stomach, unable to get into the bloodstream quickly because the morphine has slowed digestion to a crawl, well, the clot in the heart just keeps growing.
Wow. So by treating the pain, you're accidentally stopping the cure.
Exactly.
You're creating a traffic jam in the stomach that prevents the emergency vehicles from reaching the heart.
Precisely. It's a cascading effect that evidence-based medicine has finally caught up with.
Okay, so if we aren't relying on oxygen and morphine right out of the gate, let's look at the actual logical sequence of solving this problem.
Right.
First, we have to stop that massive pileup of platelets. That brings us to the antiplatelets.
The A and the T in Batman.
Exactly. The guideline says give aspirin 300 milligrams stat, meaning immediately, plus a P2Y12 inhibitor.
Yeah.
And there's a fascinating backstory here.
Oh, definitely.
The notes specifically point out that ticagrelor or prasugrel are preferred over the old standby drug, clopidogrel, based on the Plato and Triton clinical trials.
Yeah, antiplatelets are the absolute foundation of treating that ruptured plaque.
Yeah.
You have to stop those sticky platelets from clumping together and making the highway blockage worse.
Right.
Aspirin works on blocking one chemical pathway, and the P2Y12 inhibitors work on blocking another.
So hitting it from two sides.
Exactly. By hitting both pathways simultaneously, which is called dual antiplatelet therapy, you get a much more robust effect.
And what about those trials?
Right, those clinical trials you mentioned, Plato and Triton, were essentially massive high-stakes showdowns in the medical community. They pitted the old standard drug, clopidogrel, against these new upstarts.
And the new guys won.
The data definitively proved that newer drugs like ticagrelor are simply more effective at preventing death in acute settings.
Wow.
Though, the notes do warn that ticagrelor has specific contraindications, like a history of stroke, that doctors must absolutely watch out for.
Okay, so we've frozen the platelets, but the patient is still in agony and the blood vessels are tight. How do we relieve the pressure safely?
That's where nitrates come in.
Right, nitrates. They are used for pain relief, usually given under the tongue or through an IV, and they help dilate or open up the blood vessels.
Correct.
But the notes have a massive flashing warning sign here.
They do.
Avoid nitrates if the patient's systolic blood pressure is under 90, if they're having a right ventricular infarct, or, and this is a big one, if they've recently used a PDE5 inhibitor.
Yes.
For those who don't know the clinical jargon, a PDE5 inhibitor is the class of drugs that includes Viagra.
This is a critical safety check. Nitrates work by dropping blood pressure to take the workload off the heart.
Right.
But if the pressure is already dangerously low, or if the right side of the heart is failing and needs all the fluid return it can possibly get, well, giving a nitrate is dangerous.
And the Viagra connection.
If a patient has taken Viagra recently, which also aggressively dilates blood vessels, combining that with a nitrate will cause the patient's blood pressure to crash completely.
Oh, wow.
Yeah, the bottom falls out, and it could be immediately fatal.
That is a highly memorable and incredibly important piece of medical trivia.
Very important.
Okay, next up in the sequence, beta blockers. The guidelines say these should be given orally within 24 hours to slow the heart down, but to avoid giving them through an IV in cases of acute heart failure or bradycardia, which is a slow heart rate.
Yeah, beta blockers are essentially the brakes on the heart. They make it beat less forcefully and less rapidly.
Okay.
This decreases the heart's demand for oxygen, which is exactly what you want when the supply line is blocked. But if the heart is already failing and barely pumping or beating way too slowly, stepping on the brakes with an intravenous beta blocker will stall the engine completely.
Makes total sense. And finally, to complete the Batman protocol, we have anticoagulants.
Yes, the final piece.
The notes list a bunch of intimidating pharmacy names like unfractionated heparin, enoxaparin, fondaparinux, and bivalirudin. But instead of just listing drugs, let's talk about what they actually do.
Good idea.
While the antiplatelets stop the platelets from clumping, these anticoagulants stop the actual coagulation cascade in the blood.
Exactly.
They essentially freeze the wet cement of the clot so it can't harden, solidify, and spread further down the artery.
That's a perfect way to put it. When you look at all these medications together in sequence, the antiplatelets to stop the clumping, the nitrates to open the vessels, the beta blockers to slow the engine, and the anticoagulants to freeze the wet cement.
Yeah.
You see that the entire medical strategy isn't just about rushing blindly to a surgical fix. It's about medically stabilizing a chaotic situation, preventing the clot from getting worse, and protecting the remaining heart tissue from further stress.
So what does this all mean? We started today by talking about the frantic, chaotic medical dramas on television, and what we've discovered is an incredibly elegant, evidence-based system.
It really is elegant.
We broke down the plumbing problem, how microscopic vulnerable plaque ruptures, causing a massive traffic jam of platelets.
Right.
We learned that the level of that highway blockage determines whether you have unstable angina, an NSTEMI, or a STEMI.
And we also saw how doctors play brilliant detective using high-sensitivity troponins to deduce if heart cells are popping open and using the physics of ECGs to spot ST elevations or depressions.
Yeah. That electrical map determines whether a patient is rushed to surgery in 90 minutes or safely managed medically over 24 to 72 hours.
It's incredible precision.
It is. And most importantly, we saw how these updated guidelines completely overturned conventional wisdom.
Yes, the shift from M&AB to the Batman protocol.
Right, showing us that routine oxygen can actually cause dangerous vasoconstriction and that morphine can delay vital anti-clotting medications. It is a stark reminder that medical knowledge isn't static. Understanding these concepts, even as a layperson without a medical degree, makes you an infinitely better informed advocate for your own health and the health of your loved ones. When you're in that scary ER room, you won't just see chaos. You'll understand the why behind the protocols.
And, looking deeply at the why brings me back to a very brief but deeply profound point in the source text that we touched on earlier.
Oh, type 2 MI.
Yes. Type 2 MI, or secondary ACS. This is demand ischemia, a heart attack caused by sepsis or severe anemia or extreme systemic stress without any plaque rupture in the artery whatsoever.
Right, the heart essentially starving itself to death just from overexertion, trying to keep the rest of the body alive.
Exactly. And I think that leaves us with an incredibly compelling final thought to chew on.
Let's hear it.
If a heart attack can be triggered purely by systemic demand, if extreme physiological stress somewhere else in the body can cause the heart to fail without a single blocked artery, what does that mean for how we view health, inflammation, and stress overall?
That's a great question.
It suggests that protecting your heart isn't just a simple mechanical matter of managing your cholesterol to keep your literal pipes clear.
Huh.
It is fundamentally about how your entire body manages and processes extreme stress, systemic infection, and physical demands.
Right.
The heart might be isolated inside the chest cavity, but it is deeply, intrinsically vulnerable to the chaos of the rest of the human system.
It really puts the deep interconnectedness of the human body into perspective.
It really does.
It turns out Whether it's navigating the tension of a TV drama or standing in a real-life ER, managing the chaos of the whole system is the only way to truly save the heart. Thank you for joining us on this